I've used load testing for years, and it's a good tool, but it's not definitive. The next thing you hear is Doppler auscultation. Doppler is used when you want to try and differentiate lateral pole versus medial pole problems. And as a result of that, it's a great diagnostic tool. The premise it works on is that our jaw moves two ways. When we rotate or hinge, we load the medial pole, and when we translate or guide, we load the lateral pole. Now, again, it goes back to what we talked about before when we were talking about that disc functioning when we were looking at the cadaver video. If you have smooth top of the bone against smooth underside of the disc, you're not going to generate a lot of noise. All you're doing with Doppler is the same thing as you're doing with a stethoscope. You're listening to the tissues rub against each other. That's it. You can do the same thing with a stethoscope, but with a Doppler, the patient can hear. So it allows you to have the conversation with the patient about what's going on not only on the medial pole, but the lateral pole as well, because more likely that's where you're going to hear noise. But Doppler, again, is a great tool, but it doesn't definitively diagnose joints. You hear a lot today about joint vibration analysis, which basically works on the same premise. What you're doing is you're having a patient wear a monitor where it's going to start to record the sounds that are made. The smoother the tissues rubbing against each other, the less noise. The more structurally altered and damaged the tissue is, the more noise you're going to hear. That's going to come up on a computer screen, and then you can start to make interpolations based upon what you're seeing on the screen. Again, a great tool, but it's like load testing, it's like Doppler, it's a screening tool. You cannot definitively diagnose with any of them. Doesn't matter what it is. The only way to definitively diagnose is with joint imaging. And you know, you think about it, as a profession, it's amazing when you take a look at dentistry how we have resisted imaging the joints over the years. If you take a look at the system here, we have mineralized tissue on the back end of the condyle, mineralized tissue on the front end of the condyle. On the front end of the condyle, teeth wear, teeth break, teeth decay or necrose or demineralize, and we treat those. There's courses on treating the worn dentition. Unbelievable amounts of information on restoring cracked teeth. Decay, cleaning out decay, we do it every day. But somehow the back end of the joint gets ignored. It has the same problems. We see on the back end of the joint worn bone the same as we see worn teeth on the front end. We see cracked condyles on the back end the same way we see cracked teeth on the front end. We see necrosing condyles on the back end the same way we see decaying teeth on the front end. We never treat it though, because we never see it. If we never see it, we assume it to be healthy, when in reality, these patients aren't crazy. They have legitimate reasons why they're coming in for problems, and we're seeing legitimate breakdown that warrants imaging, but somehow we're not ready to image yet. So at some point when we have to start to recognize when to image, it becomes a little bit easier. So really imaging, I always think about imaging if I suspect I have a medial pole problem. That's when I'm going to image. Now it's easy to say that, but it's kind of difficult to know when you have a medial pole problem. So let's do a little more clinically based guidelines for imaging. I'll image if I have moderate to severe pain in the joints. Michelle came in, Michelle had a lot of pain. If we take a look at her MRI, we can see the condyle. She's got erosive changes on the surface of the bone. She's 26 years old. We can see the joint socket, and now we see the disc. Big disc sitting right out in front of the bone. Again, if I can get a small disc sitting out here, I'd rather have that than a big disc sitting right in front. Her other joint, condyle, she's had some erosive changes as well. And again, now you're seeing the change in the disc as well. She's also had a change in the vertical dimension of her joint. You can see that. And a horizontal dimensional change on this side. Image for her. I'm going to image if I have an overjet that's greater than 3 millimeters in a fully seated position. So if we take a look at Lindsay, when we image her, what do you think her joints are going to look like? Same exact thing. Bone degeneration, loss of horizontal dimension, and a big disc sitting right out in front. Next case we're going to image for is an overbite a negative overbite in a fully seated position. This is Sammy. There's the negative overbite. What do you think her joints are going to look like? Same thing. Small bone, big disc, lots of pain on her. Here's the problem with the small bone, is that eventually it's not going to be able to withstand the forces. Think if it was her hip. If this was a 17 or 18-year-old girl when I saw her with that amount of dimensional change in the hip, how would they be treating her? Differently than we treat her, for sure. Because as a profession, we never see it. If you don't image, there's never a problem. If you image, that makes your world more difficult, quite frankly, because you start to see more. But it also allows you to solve more problems, which is really what we want to be able to do. And the last is, I have a facial asymmetry, I'm going to image. Take a look at Lori. Pretty obvious where her bad joint is, isn't it? Now when you start to look condyle to chin point, it's her left side. Here's her right side. She's already bone to bone here. This is a cone beam, by the way. That would be different than an MRI. Only shows hard tissue. So in this case, what you're going to do in your mind's eye, you're going to pretend that that disc is sitting right in that area. So what you're going to do when you're analyzing a cone beam is you're going to look to see, is there adequate space where I could draw a disc in if it was a healthy disc? And the answer is no. Now, when you look at the left side, though, it's going to be very obvious as to what the problem is. Now, when you see the left side, you can see that's totally worn down. How many millimeters of space do you think she's lost on that condyle when you take a look at it? You know, it has to be at least 3 millimeters of space. When you see a 3 millimeter dimensional change in the condyle, that translates to a difference in the bite. If you had a crown that came back from a lab technician that was 3 millimeters high, would that impact the bite? Same thing. It's all about dimensional changes. And when you start to see dimensional changes, it's going to impact itself in the occlusion, either through an open bite in the front, through intruded teeth in the back, or worn teeth in the back. Okay? That space has to go somewhere. So, what we're going to look at when we image is disc condition. We'll look at that on the MRI. Disc position, we'll look at that on the MRI. Condyle condition on the MRI. Condyle position, we'll look at MRI. The potential for retrodiscal change, that's how far that condyle can perforate through until it hits bone. A little bit, not too much change. A lot of bit, big potential for bite changes. We'll look at the condyle to fossa ratio. How snugly does that condyle fit in the joint socket? And we'll look at condyle surface area. The top picture I showed you, that's ultimately where the load's being distributed. That has to be wide enough and long enough to distribute the forces. If that's a skinny little sliver of bone, it's not going to make it. And then ramus length. That's going to give us an idea of how well we've had mandibular growth. I'm just going to show you a few scans to give you an idea of what we're looking at. In terms of disc position, okay, what I'm going to ask you to do is to think about disc position like a clock face. I'm going to ask you to look and see where the posterior part of the disc attaches to the condyle. We good on that? Here's the front end of the disc. The back end of the disc attaches right here. Everyone see that? If you were going to put a clock face on that, let's call that 1 o'clock. Next, as you start to get disc displacement, that ligament starts to stretch or starts to tear. Everyone with that? As those lateral and medial ligaments start to stretch or tear, the top part of that disc starts to come off, and now we've got a disc that looks like this. Now, when you take a look at those two pictures, what's the difference? Instead of that condyle being in the central bearing area of the disc, now it's on the posterior band. And if we look at the front end of the disc, we can see the anterior band here. There's your attachment. Let's call that 12 o'clock. Okay? What do you think happens in this case? What's the potential occlusal change here? Actually, this is the case that's probably one of the more difficult ones to recognize, because here you have an increased vertical dimension. You're on the thicker part of the